Thank you to Dr. Singhal and Dr. Slavin for the invitation to speak today. I was asked to speak about lymphedema surveillance, who and for how long. So at Massachusetts General Hospital here in Boston, we have had a prospective lymphedema screening program in place since 2005. We screened over 4,500 patients with a median follow-up time of 31.6 months. Our screening, as Dr. Kilbreth said, starts in the preoperative setting. So we get a baseline measurement on all of our patients in their pre-op clinic visit. We then see patients again in their post-op clinic visit, their multi-visit, and during each one of their oncology follow-up visits, which is about every 3 to 8 months. We purposefully see patients during their oncology follow-up visits to avoid further visits just solely for lymphedema screening. During those post-op visits, we take an additional arm volume measurement. We record symptoms, as Dr. Kilbreth said, really important to look at what symptoms these patients are experiencing in terms of quality of life, function, and signs and symptoms of lymphedema. And we educate our patients about their individual risk factors and about their signs and symptoms potentially of lymphedema, asking them to be our eyes and ears in between these clinic visits and to report things really early so we can have them in and diagnose and treat early. We incorporate this subjective data together with our limb volume measurements and our clinical examination together to diagnose lymphedema. We measure with a pyrometer. As Dr. Kilbreth said, it's our measurement tool that we have chosen. We've previously published a protocol. It is really important to be standardized in the way you're using this measurement tool. We take 3 measurements on each arm. It takes about 2 to 3 minutes each time. I won't go into this. I think Dr. Kilbreth covered any one of these measures that you could use are reliable, valid, diagnostically accurate. And we know with pyrometry that we can detect subclinical lymphedema or edema of 3% or more increase from baseline. So that's really important because we want to pick this up as early as we can. We know that obtaining a preoperative measurement is important. It's critical to screening for lymphedema, and we know without a preoperative baseline, it is very difficult to accurately diagnose lymphedema. Similarly, we took a look at 1,028 patients, over 7,000 visits, over 35,000 measurements, and we found that 2.9% of these patients had a baseline arm asymmetry of more than 10%. 28.3% of these patients had a baseline arm asymmetry of more than 5%. If we didn't know that and we were diagnosing based on absolute difference in the arm, this would be inherently erroneous. We recently published a manuscript on the importance of baseline and found that up to 40 to 50% of cases are misdiagnosed with lack of a baseline. But we also understand, as Dr. Kilbreth said, that oftentimes you just don't have a baseline. So it's nice to see work being done in absence of a baseline as well. We use the relative volume change and the weight-adjusted change formulas to quantify arm volume changes. Our group developed and validated these formulas. The one on the left, the relative volume change formula, is used for patients who've undergone unilateral surgery. It takes into account the arm volume of the affected arm, or A, and the unaffected arm, or U, at baseline, or time 1, and time 2, or day of measurement. The weight-adjusted change formula on the right is used for patients who've undergone bilateral surgery and takes into account the volume of the affected arm and the patient's body weight. These formulas can be used with any type of limb volume. They are not isolated to limb volumes taken from pyrometry. And we've previously published our validation for these formulas. So who should we screen for breast cancer-related lymphedema? Should we screen everyone, or should we screen only those patients at high risk? Our work and as our screening program has evolved, it's allowed us to learn a lot and get lessons from what we've learned. We've been able to establish risk factors for breast cancer-related lymphedema in our cohort, and we've more recently been thinking about those with really early lymphedema. We're lucky through a screening program to pick up this early lymphedema. When do we treat? Who progresses in terms of edema and who does not? So I'm going to go through some of these risk factors in our cohort now and in terms of how we educate our patients through our screening program. So the impact of axillary surgery and regional lymph node radiation on the risk of breast cancer-related lymphedema. Our team examined 1,476 patients. We prospectively screened them with baseline spirometry with a median follow-up time of 25.4 months. We found that on multivariate analysis, patients who underwent regional lymph node radiation were more likely to experience edema of greater than 10% than those who underwent chest wall radiation or no radiation. There was no significant difference between patients in terms of type of regional lymph node radiation, supraclavicular and axillary radiation versus supraclavicular only. These are the cumulative incidences in this population of breast cancer-related lymphedema 24 months postoperatively. And these are numbers we use to educate our patients about their individualized risk based on their breast cancer treatment. So as you can see, patients who undergo axillary lymph node dissection and regional lymph node radiation are the population at greatest risk. And those who undergo sentinel lymph node biopsy with regional lymph node radiation have a much lower risk of less than about 5%. Impact of body mass index on risk. We've heard a lot about this today. We looked at 787 patients prospectively screened with newly diagnosed breast cancer, and we looked at preoperative body mass index calculated same day with height and weight. On multivariate analysis, we found that patients with a preoperative body mass index of 30 or more are at an increased risk of developing lymphedema, as compared to those with a body mass index of 25 to 30 or less than 25. Impact of breast reconstruction on risk of breast cancer-related lymphedema. We looked at 616 patients, again followed for 22.2 months. 65% of these patients had immediate implant reconstruction, 11% immediate autologous reconstruction, and 24% no reconstruction. The 2-year cumulative incidence of breast cancer-related lymphedema with implant reconstruction was 4%, autologous reconstruction 9.9%, and those who had no reconstruction, 26.7%. So on multivariate analysis, we found that a high BMI at time of diagnosis, axillary lymph node dissection, and lymph nodes dissected, all risk factors in the literature, were associated with a higher risk of lymphedema. Alternatively, those who underwent immediate implant reconstruction were at a much lower risk of lymphedema than those who undergo no reconstruction. So when possible from a lymphedema standpoint, we would recommend immediate reconstruction. So then in terms of the population with these edemas under 10%, as Dr. Kilbreth said, there is no randomized controlled trial telling us how to treat these patients or when to treat these patients. So our team is wondering, when do we intervene? We can now pick up these early edemas through a screening program. When do we intervene? So our team looked at 1,173 patients over 27 months. We categorized volume changes as less than 3%, 3 to less than 5%, or 5 to less than 10%, and looked at who progressed to a relative volume change of 10% or more. So in the more than 3 months postoperative period, we found that patients who had an elevated relative volume change of 5 to 10% were more likely to progress to edema greater than 10%, whereas patients with an elevation of 3 to less than 5% were not likely to progress to edema more than 10%. This was a bit different in the immediate postoperative period, where we found that patients with edema of 3 to less than 5% or 5 to 10% were likely to progress to more than 10%. So we recommend close screening for patients with elevated arm volume of 3 to less than 5% in the immediate postoperative period. We don't think intervention is warranted at that early period, but we want to closely monitor them, and we need further investigation of this 5 to less than 10% threshold. So again, who should we be screening? All patients or those who we know to be at high risk? I think we learned a lot through evolving our screening program and screening everyone, and I would encourage people starting a screening program to try to do that if resources allow. We are moving towards a more higher risk screening process as right now. However, we will still continue to get a baseline measurement on every patient. we have tried to capture in this complex slide our screening program and how we think about intervention for these patients. This is a bit of a work in progress, and we need further studies for the population under 10%. But on the right side of your screen, well, certainly we start with baseline arm measurement, and we do surveillance every 3 to 8 months, but this would be in conjunction with your oncology follow-up visits. On the right, you have patients who have an elevated volume change of 10% or more. We know we need to be evaluating these patients and treating these patients and getting the edema down as far down as we can. As long as we're having progress, we keep going. Patients on the left side of the screen with an RVC or WAC of less than 5%, within 3 months of surgery, we are closely monitoring them because we know that they may progress. More than 3 months postoperatively, we continue to screen them because we know that they're not likely to progress, but we want to watch them. In terms of an RVC or WAC 5 to less than 10%, this is where we need to understand how this is affecting the patient. As Dr. Kilbreth said, symptoms are so important. What is the symptom? What are the symptoms the patient is feeling? What are the known risk factors? So if the patient is high risk and or with symptoms, our CLTs are seeing that patient, and we're evaluating and treating and trying to get that edema down as low as we can. If the patient is low risk, we're reassessing quickly and then trying to get edema down as low as we can if we need to treat. For how long? How long should we screen these patients? Well, if you look at different studies in the literature, median time to onset of lymphedema is 12 to 24 months, depending on the study you're looking at. There are few studies that follow patients for a very long time in terms of lymphedema onset. Norman et al. Published a JCO paper in 2009. It was a population-based study of 631 patients, 238 of whom developed breast cancer-related lymphedema. And as you can see, most of them developed lymphedema in the first 2 to 3 years. But there were still new cases in year 4 and still new cases in year 5. There was a 20-year study done in 2001 on patients who had axillary lymph node dissection 20 years prior. 77% of those reported lymphedema in the first 3 years. Our median follow-up is 31.6 months, but the risk of lymphedema is lifelong. So we would encourage people starting a screening program to screen as long as possible, minimum of 3 to 5 years, or as long as your patients will come and be screened. In conclusion, ideally, screening begins preoperatively with that critical baseline measurement. If you have that, then you know you can accurately diagnose lymphedema later. Knowing who is at risk is really helpful because we can incorporate those risk factors together with the symptoms our patients are feeling and the objective data and clinical examination into our diagnosis. It's not just a measure of volume, as Dr. Kilbreth said. We would recommend using a relative volume change equation which takes into account the patient's baseline. Patient vigilance is a large part of our screening program. I will tell patients, please be vigilant, but not fearful. Just let us know. If you have any subtle changes, call and come in. We would recommend that you consider screening for a minimum of 3 to 5 years. Thank you.